Good afternoon. Instead of talking much about ourselves, let me tell you the story of Joseph, this little child in the country of Malawi. Joseph is a zero-dose child. What that means is he's one among many such children who's just for the first time receiving a vaccine. These are among the required vaccines like tetanus and diphtheria that if children don't get them at the right stage of their development, it can cause debilitating disease, death, or possibly even infection for neighboring family members and community members. Now, Joseph is clearly not alone. In fact, in 2021, the Global Vaccine Alliance, Gavi, estimated that there are about 18 million children between the ages of 0 and 5 who could be considered zero-dose. So the scale of the problem is massive. And a lot of these children tend to be located in so-called FCV countries, fragile, conflict, and violence, which means it's very hard to get to them, and it's very hard to collect data on trying to understand what's really driving the nature of the zero-dose issue. It's not just limited to vaccinations, it's also related to malnutrition. So Nutrition International, another eminent NGO in the public health space, estimates that about 45% of the deaths for children between 0 and 5 are related to acute malnutrition. So even a single supplement like vitamin A could potentially reduce the risk of mortality by about 12 to 15% just through one nutritional supplement. So how should we think about assisting public health organizations to deliver interventions? Obviously, a key part of this question is knowing where zero-dose children are located. And so as you can guess, a lot of this talk is about how to locate their zero-dose child in the community that they are present in. So public health and nutrition science have actually taught us a lot over the last few decades about the factors or the determinants of what's likely to make a child zero-dose. But here we have to think about how this knowledge is produced. So for example, here I have two studies. One is an academic study that has collected systematic evidence and published in peer-reviewed format in a journal of global public health, the determinants of what causes likelihood of a child becoming zero-dose. So there's a wealth of information contained in this peer-reviewed science. Another example is this report by Gavi that is demonstrating how an intervention can be planned and programmed to deliver vaccines or other nutritional supplements for these children. But a lot of this information, the rich context, is buried in these documents. And so one way to think about this rich knowledge contained in them is through an ontology. An ontology is a construct that links together disparate pieces of knowledge. It describes hierarchically and logically how to think about data, factors, and determinants of a prediction problem. So just a simple example, we can already anticipate that if a community doesn't have access to water and sanitation infrastructure, that could lead to a prevalence of waterborne diseases. So that can be part of an ontology. It can hold clues as to what data we need to look for to try to understand where zero-dose children are likely to be located. In spite of this knowledge, zero-dose children are often missed in a lot of public health programs, whether they're in urban slums, in rural areas, or in other conflict regions. And part of the challenge is that where data exists, it might still be very hard for public health organizations to make use of the heavily sort of dimensioned and rich sort of data that exists in geospatial formats and make that useful for program planning and for targeting interventions. Let me give you an example of that. What's shown here is one of the gold standard surveys that the public health community has for regions like Malawi. It's called the Demographic and Health Survey. It's conducted by an organization called USAID. Now, these surveys are extremely rigorous. They're very well planned, and they're systematically administered. But that rigor comes at the cost of time and expense and diligence in going out to the field to collecting that information. Now, in many contexts, especially fragile and conflict zones, such a survey may not be possible. And this might be the most recent version of that survey, very difficult to repeat over and over again and administer and then make those results available to those who are best able to use them. A final aspect of this is that this report is 700 pages long. So for someone who is trying to build a map or some way to understand how to target programs, they would need to go through this systematically, look at the data codes and the survey protocols, and extract from that useful information to inform their program targeting. What public health organizations addressing the zero-dose child really need is something like this: modern, cloud-native, interactive, geospatial analytics that can place insights for program planning and targeting at their fingertips. So why Atlas AI? Why our company? What can we do to help this problem? Atlas AI is a software engineering company. We were started by 3 professors at Stanford University, one in remote sensing, one in computer science, and the other in development economics. So about a decade ago, these professors were occupied by a question: can we use satellite imagery, remote sensing, and machine learning to estimate the socioeconomic well-being of every community on the planet, especially in data-sparse environments where there's no other alternative? For example, the Democratic Republic of the Congo, the last full countrywide survey that they conducted was in 1984. So being able to get current insights about the nature of communities, the demographics, and those economies continues to be vital today in these data-sparse environments. So the short answer to that question that occupied the professors is yes. They released that technology and published in journals like Nature and Science. And that research was found by organizations like the Rockefeller Foundation, who encouraged them to bring that technology out of the lab and make it available for mainstream use for public benefit applications. As a result, Atlas AI was started as a company, a public benefit corporation, where we recognize that the technology that we build is not mutually exclusive or exclusive to profit or public benefit and public goods. In addition to producing those socioeconomic indicators, we were encouraged to go beyond. And what's shown here are some of the indicators that we produce today. Detailed information on demographics, on the makeup of communities, agricultural productivity, the extent and quality of infrastructure, and the presence of some of these assets on a global landscape. Just one example of the Atlas of Human Settlements product that Atlas AI produces today on a planetary scale. This is the most current, freshest data product delineating the extent of human settlements anywhere on the planet. In comparison, another alternative product is 5 years too old. And our ability to refresh this on a weekly, monthly, or annual basis is truly powerful. And this creates a substrate that we can build on with other data indicators. And so if you think of Atlas AI, think of us as the company that's building the socioeconomic digital twin of where community development is taking place on a truly global scale, for the opportunity for understanding vulnerability and how to build supply chains to bring interventions like nutrition and vaccines to communities that need them the most. So we were approached by our partners in the public health space as a technology company to see where we could bring some of our stack to bear on this type of problem. And so we developed an impact intelligence platform to identify those children who are the most likely to become zero dose. So this is a prediction problem, and we were going to use these predictions to inform the delivery of nutrition and immunization programs. So we built this platform with 2 objectives in mind. The first one is prioritization for targeting. Where can we make sense of where limited resources can be deployed in a time-sensitive manner? The second one is a question of efficacy. Do those programs actually reach the communities and the beneficiaries who are most likely to benefit from them? So we've since deployed this program in several countries and are working with subject matter experts and health practitioners in public health and in vaccination delivery to actually bring this technology to bear on the supply chain issue. What's shown here is the fast-forwarded implementation of that zero-dose ontology that I mentioned at the beginning. So on the left are shown community factors. Again, this is trying to understand if a community has access to infrastructure like water and sanitation, which is predictive of certain community health outcomes. What's shown in the middle is household factors. For example, is there a single parent living in that household? Was there a recent report of tuberculosis, which is predictive of other health conditions? And finally, the third area is access factors. Do those children and their parents or families have the ability to take them to a nearby school or a healthcare facility for a vaccination drive or for nutrition supplements? Now, each one of these implementations gives you a slightly different answer, as you can see from the data overlays and the predictions. And so the test really here is to work with the subject matter experts in public health to understand what is the benefit of the intersection and how to dial up and dial down so that they can understand the value of targeting and prioritization. So what's shown here is then the implementation in Carto in cloud-native format. So as you can see, layers such as the health facilities and roads being turned on and off, geometries being represented, like the district boundaries, where the analysts can filter based on their region of interest, especially in working with a program partner in country or a local government that's thinking about a program or a vaccine drive for their region. Let me tell you a little bit about the settlements that are shown here in terms of rural, urban, or peri-urban. So this is the true representation of the Atlas of Human Settlements, a 10-meter resolution ground surface distance raster and vector product that describes not only the extent of settlements, but also the density and the change in the built-up environment in each of these communities at a truly global scale. And then finally, by using routing algorithms and other types of optimization techniques, the ability to understand how to be able to get some of the vaccines to the locations where these children are, or to be able to bring families to locations where these interventions can be administered. So let me summarize what I've shown you here. We know a lot about, as a community, about what's likely to make a child zero dose. But those who would benefit from these interventions are often very, very hard to find. So a big part of the power of geospatial analytics in the cloud is to be able to integrate some of these data sources and predict the likely location of these beneficiaries. Second idea is that organizations who have the resources and know-how to intervene could benefit from having these tools at their fingertips. So by working with subject matter experts in our partner organizations, we're bringing this technology to them through machine learning programming and through other types of modalities that can then set up downstream performance monitoring for them. And finally, we recognize that as technology providers here, we're not the true experts in understanding how science is bringing to bear sort of the benefits of evidence, of treatment, of feedback loops. And so we truly believe that this type of technology needs to be deployed in partnership format, working with public health organizations and practitioners who are best equipped to build capacity in country, best equipped to advise policymakers on how to resource such programs, and then bring those feedback loops back into the data system so we can do better and better.